Hello, this is Dr. Raul Nath, and in this video we'll be talking about one of the common frequently asked questions that we get at Texas Nerve and Paralysis Institute. And this will be the first video in a series that we try to answer some of the more common questions that we get asked. One of the questions that we hear frequently is, why does my child need 3 surgeries? And while it's true that the core problems that occur in most of these children generally include 3 particular problems that do require surgery, not every child requires 3 surgeries, and not every surgery is done in the same sequence. As with anything else in life and in medicine, every child in every situation is individual. So there are 3 common surgeries, but they could be 1 or 3 or none. And sometimes children with severe injuries that include the hand, they need potentially more, especially if there's shortening of the extremity. But the purpose of today's video is to talk about the 3 most common problems that occur in the obstetric brachial plexus injury population, and the surgeries that are designed to help those particular problems. So the most common problems that occur are that the muscles of the shoulder get too tight in a particular way, and we'll talk about that in a few minutes. Secondly, the dislocated shoulder, and it's not apparent to non-specialists and to parents and to many therapists that this particular posture, the resting posture where the arm is turned inward and is shortened, that's a dislocated shoulder until proven otherwise, and that's caused by these tight muscles, which cause several problems, but one of them is the dislocated shoulder. And then finally, the tight biceps muscle. This also occurs as a result of the particular type of injury that most children get. So we'll talk about each of those in sequence. Prior to that, though, it's important to notice that in 1905, R. Whitman described that the nerve injury in the brachial plexus of the newborn results in fibrosis of the muscles, in other words, contracture or tightness, and eventual bony deformity. And by that, he means the dislocation that we talked about briefly. So here's a diagram of the brachial plexus. We can see that the upper part of the brachial plexus is most commonly injured 85% of the time, according to some studies, and the lower roots are about 15% of the time. So the upper trunk controls the shoulder, and importantly in obstetric brachial plexus injuries, the ability to lift up and to rotate outwards. So when that upper trunk is injured, the shoulder ends up turning inward and downward, and the patient has difficulty lifting upward and difficulty rotating externally, and ultimately the arm hangs in front in that posture that we showed in the previous image. The other thing that happens with the upper trunk injury is that the child or the adult has difficulty bending the elbow flexion. That's the biceps. So what then ends up happening is that we have this primary injury to the nerve, which leads to muscle imbalances, and then those ultimately result in twisting of the bones as they develop, and then in certain of these patients we end up with a shortened extremity that has that internal rotation posture that we talked about. That's a shoulder dislocation. So one of the common ways that this is approached is by repairing the nerves, thinking that that would potentially avoid the muscle and bony problems. However, a survey was done several years ago, 2006, among surgeons who identified themselves as obstetric brachial plexus surgeons. 22 of these surgeons were surveyed, and most of them believed in nerve grafting or repairing the nerves. 75% of these patients, of these surgeons, however, treat less than 15 patients per year, roughly 1 a month. It's a very low volume and a very low experience, and I think that's the reason that nerve injuries are thought to be the answer to this injury, and in my opinion, it often or mostly is not. There's several research studies that show that grafting is not as important as some think, and it the research does not support frequent grafting. I did a paper myself in 2009, and what that showed was that if we look at patients who've had the brachial plexus injury, the eccentric brachial plexus injury, and we look at a group that had nerve grafting versus a group that didn't have nerve grafting, at age 5 they're pretty much the same in terms of function, and the nerve grafting patients might actually have a little worse shoulder problem or shoulder problems, and in fact they ended up having more overall surgery, and the outcomes I think were less than desirable. So nerve grafting is not the answer. In fact, nerve grafting probably leads to more shoulder problems. Other studies have shown that around half or 45% of children end up with these muscle complications like tightness and contracture. Roughly a third end up with the bony complications or the shoulder dislocation. Again, what happens is that the muscles become too tight here. That's that difficulty lifting and rotating outward, and ultimately that ends up, that tightness, rotating the arm out of the joint, so now we've got a dislocation situation at the shoulder joint. Here's an example of a nerve graft. The scar, or what was thought to be the scar, was removed, and then nerve is taken from the leg to try and repair or try and reconstitute what that normal nerve looks like. However, those patients still end up with this problem, which is the two shoulder issues that we talked about, and we'll talk about again, and then the elbow problem. They still end up with that regardless of whether they've had nerve grafting, as this child had done in infancy. So the tight muscles of the shoulder, problem 1, it prevents overhead lifting of the shoulder. These are two sisters who unfortunately had the same injury. Problem 2, the shoulder dislocation. The arm can be twisted all the way backwards, or more commonly just like this, rotated internally with that elbow being bent, and the shortening. That shortening occurs not so much that the arm is really short, but because it's forced out of the shoulder joint, then that of course makes the entire length of the arm appear shorter. But that's the characteristic posture that we see with a shoulder dislocation. And then the third problem we talked about is the tight biceps. The biceps tightens up so that we have this continuous bend. You can see it in the operating room. This one's about 65 degrees or so at that time. And so those are the three problems that we identified early on in this talk. So the tight muscles, what we do is what we call the modified quad surgery. There are videos talking about that in more detail elsewhere in our Instagram and Facebook pages. So here's a child who can't get beyond about shoulder level. This is after the modified quad, excellent range of motion. This child is also right around shoulder level, and you can see she gets much better after the modified quad surgery. The shoulder dislocation, here we can see those characteristic postures, and here we can see after the surgery straightening and also length improvement. And that's just because the arm is now back in the shoulder joint, so we get the normal length, or hopefully close to normal. This child here, we can see that very abnormal attempt to get the hand to the mouth. It's upside down and backwards, and then we get a better or more natural direction of movement of the shoulder, which is what we want. So as an example, to show several of these features, here's a child as a toddler who's got the inability to lift overhead, the internal rotation. This is after the modified quad surgery. We see improvement in the overhead, but there's still a length discrepancy. So then the triangle tilt, instead of having the bent arm that's shorter, we now get normalization of length, better direction of elbow and shoulder movement, and also the ability or improvement in supination. This is one of the more important features of modified quad in the triangle tilt surgery. Here's a child CT scan, which is a slice through both shoulders. This is the left side and the right side. We can see the left arm is sitting in the scapula or the shoulder joint, just like an ice cream cone. And on the injured side, that line is not there. The arm has dislocated out the back. So this is the back, that's the front, and we can see that there's some destruction of the shoulder joint as well. This is a year after modified quad and triangle tilt surgery, same child, same CT scanner. Then we can see how much improved not only the placement of the arm is in the shoulder joint close to normal, but there's also been reconstruction or regeneration of the shoulder joint, and that can happen in children, which is a fascinating phenomenon, and helps to explain the good results of the modified quad and the triangle tilt surgery. Biceps tendon lengthening, we can see the bent elbow, and through the biceps tendon lengthening surgery we can get that elbow straighter so that the anatomy, function, quality of life all seem to improve after that. Now, all of these concepts and more are available in my book, Obstetric Brachial Plexus Injuries, the NATH Method, and that's available free online as a downloaded PDF. You can also order a paper version of that on Amazon. That's not free, and so it's much easier just to download the PDF version from the website. So that's been a frequently asked question video on some of the more common surgeries that end up being needed in children and adults with obstetric brachial plexus injury. Thank you.